Good evening and welcome to our webinar, Treatment Options for Overactive Bladder, presented by Dr. Lisa N. Hawes. So right now, I'd like to introduce Dr. Lisa Hawes. She has been a practicing general urologist since 2004 and specializes in female urologic conditions, including incontinence, pelvic prolapse, urinary tract infections, and interstitial cystitis. She also focuses on kidney stone conditions and disease. Dr. Hawes is a frequent speaker on female urologic conditions such as urinary incontinence, overactive bladder, and pelvic floor issues in women. We'd like to welcome Dr. Hawes. Thank you all for joining us.
Hi, good evening, and thank you for taking time out of your evening to come listen to me talk a little bit about overactive bladder. As Jennifer said, I'm Dr. Lisa Hawes. I practice at the Fulton office of Chesapeake Urology, so that's down in Howard County. And I just wanted to take a little bit of time tonight to briefly remind you about overactive bladder, although you all are here, you probably don't need reminding, but exactly what that means and what some of our basic treatment options are. But then I want to spend a good amount of time on something that's brand new and super exciting and probably the best thing to happen in overactive bladder in the last decade, if not in the last 20 years. So without further ado, let's get started. As most of you all know, overactive bladder is a constellation of symptoms, the hallmark of which is urinary urgency. I got to go, and I got to go right away. Can't get in the door when I'm getting out of the car. Can't wait in line to get to the bathroom. Get out of my way. Okay. The other thing is frequency. I got to go all the time, and then leakage. I can't get to the bathroom in time. I can't get my pants down fast enough. So those three symptoms sort of define what overactive bladder is, but urgency is the most important portion of that. So I just want to let you know that you're not alone, no matter what you may think. No women in particular talk about this. So everybody thinks they're alone. It's sort of our dirty little secret that I might be wearing pads. But well over 50 million Americans, and again, this number may be an underestimate because people don't talk about it, suffer from incontinence. And there are a bunch of different kinds of incontinence. But overactive bladder, the urgency and urge leakage is by far the most common problem. So the other issue that's even more silent is fecal incontinence or leakage of stool. And I can't tell you how many people you have to ask them. They come in and talk to me about leaking of the bladder, but they don't mention the bowel. But if you ask, they have it. So it's much more common than we realize, much more embarrassing, much more secretive, and yet we can treat that too. So I encourage everyone here, if you have that problem, to talk to your primary care doctor, talk to your urologist, because we can do something about that too. First of all, let's talk about exactly what's going on. The bladder does two things. It stores and it empties. Unfortunately, it doesn't always do both of those things properly. Sometimes it doesn't do either of those things properly. But in general, what we talk about is, as you see, overactive bladder, meaning that the bladder is squeezing uncontrollably when you're not ready for it. And so you'll leak, you'll have to rush to the bathroom. On the flip side, you can also have urinary retention where the bladder is underactive and doesn't squeeze well enough to get the urine out. You may be going all the time, but it's just not coming out all the way. And then finally, as I mentioned, leaking of stool, it can be complete bowel leakage. It can just be a little smearing or staining, but all of that can be taken care of as well. So normal bladder function, like I said, the nerves come off the spinal cord and innervate the bladder. And the bladder is just a big muscle, okay? The bladder fills as you drink. And then when it gets to a certain volume, it sends a signal to the brain. Hey, remember I'm here, time to go. Then, you acknowledge that, you get to the bathroom, you send the signal back, go ahead and go. You relax the sphincter, the bladder squeezes, and the urine comes out. And when you're done, the exact inverse happens and you go on your way. That's great when that happens just that way. But so there are a lot of different players in this. There's the nerve, and there's the muscle, and then there's your ability to recognize what the nerve is telling you. As I mentioned before, urgency, frequency, urge leakage, but I didn't mention one of the hardest things to treat is actually getting up at night or nocturia, and a lot of people have that as well. Now, that may be not a bladder issue, If you have sleep apnea that's not treated, that can be the cause of getting up at night. If you get swelling in the leg during the day, that can be the cause of getting up at night. But still, there are a group of people that just have problems getting up at night, small amounts of urine when they do urinate. So what happens? You get that signal. Maybe the bladder's not really full. Maybe it is, but you got to go. You rush off to the bathroom. Hopefully there's no line. You get in, you go. Next, you know, 20 minutes later, an hour later, you're looking for the next bathroom. So the problem with this is it makes people afraid to go out, makes people know where all the bathrooms are, and they miss out on a lot of things in life, a lot of family events, because they're afraid to go to the ball game because they don't know where the bathroom's going to be. Is it going to be clean? Is there going to be a line? So people start curbing their activities. Same thing, even worse, with bowel function. Okay, so the normal bowel function is that the rectum stores stool, should sit there. When there's enough stool in the rectum, you get this pressure, signal goes up to the brain. You recognize that, you have time to get to the bathroom, you sit down and you evacuate. End of story. Again, all those signals have to be working properly. The nerve has to go to the brain has to recognize it, you have to be able to get to the bathroom in time, and you have to be able to relax and actually move things through. So there's a lot involved, maybe even more in bowel than bladder. The same thing is with bladder. You can have urgency to have a bowel movement. You can have leakage, or you can have complete loss of control. So as I mentioned earlier, this becomes has a huge effect on your life, right? You're afraid to go out. You know where all the bathrooms are. You miss events for the family. You can't go to meetings at work. You're afraid to fly. It creates incredible anxiety in our lives. We can do something about that. For the longest time, we've been treating overactive bladder. When people come to me, one of the most important things I like people to know is there are some simple things you can do, okay? This is not something you did wrong, but there are some things you can do to make it better. The first thing I always talk about is diet changes. What can you do? So certain foods make the urine more acidic, and that makes you have to go more frequently and urgently. That acid urine is really irritating to the bladder. So all the stimulants are coffee, tea, carbonation, acidic fruit juices, alcohol, chocolate, tomatoes, spicy foods. The good news is they're not all going to be your triggers, okay? But what I want you to do is pay attention on a day when your urgency is worse. Think about what you ate in the last 12 hours and see if you can maybe, by keeping a log, recognize, oh yeah, when I have my coffee or when I have my spaghetti. And then you can either choose to have those foods, but recognize that you might have those symptoms. You can avoid those foods, or actually there's a over-the-counter medicine called Prelief. Relief with a P in front, Prelief. And you can buy that from different vendors, and that can help if you're going to eat that food that's a trigger food. But be aware of that as a definite effort that you can make on your own without even seeing a doctor. The next thing you can do is Kegel exercises. And I know we've all heard that, right? Tightening the pelvic floor muscle. Tighten, loosen, tighten, loosen. But it definitely helps, and helps with both the bowel and the bladder incontinence. So if you can practice that 5 minutes a day at stoplights, when you're washing the dishes, whenever, that's going to help. It may not be a home run, but it's definitely going to help. So you've done all those things at home. You've tried the diet. You've tried the exercises. You've tried, everything else you can do, like limiting what you drink. And yet here you are, still having incontinence, bowel or bladder or both. So I recommend talk to your gynecologist, talk to your primary care doctor, but seek out care, because they can help you. And if they can't help you, they can send you to somebody who can. So again, the first step here on the slide is seeing a doctor. Doesn't have to be a urologist to begin with. Start even at the basics, particularly for women with a gynecologist, and for both men and women with the primary care doctor. Typically, they're going to just tell you what I did, but after that, medicine is our first line of therapy. If medicines fail, then we move on to other options. So let's talk about this. What do we do with medicines? By the way, it's the same thing with retention and fecal incontinence. I want you to do the exact same thing, talk to somebody. So once you've tried the diet and once you've tried the behavior, if you look at the bottom of the screen, we're going to talk about medicines. There are basically two types of medicines that you can try. The old standby medicines are what's called anticholinergics, and they inhibit that bladder squeeze, okay? They work on the motor muscle to inhibit this squeeze that's making you rush to the bathroom and leak. They are the standby. They've been around for 20 years. They work fairly well. It's one pill a day, but it's every day, and it's pretty much for the rest of your life. So that's a real commitment. On the other hand, it's easy, right? You just put another pill in the pill box. The problem with those drugs is there's a 5% risk of constipation, and they are very drying. So a lot of people notice dry mouth. Okay, new to the market is what's called the beta-3 adrenergic agonists. And there's only one drug in that class at this point called Myrbetriq. And what that does is work on the muscle to facilitate storage. So the bladder fills more before you feel the need to go. So instead of inhibiting anything, it facilitates. So it works on a completely different receptor with the same end result. The beauty of that drug is it doesn't dry you out. It doesn't cause constipation. It can raise your blood pressure a point or two, so it's contraindicated in anybody that has sort of elevated blood pressures or uncontrolled high blood pressure. So you've tried your medicines and they failed. You're not a candidate for medicines because of other medical problems, or you just plain don't want to do a medicine. There are some advanced therapies that we can try that seem to work very well. The first, which is pictured here, is what's called peripheral tibial nerve stimulation. And what that means is that the nerve that goes down to the bladder from the spinal cord also has a little root that goes all the way down, believe it or not, to the inside of the ankle, if you look at that picture. That nerve we can stimulate to try to change the innervation of the nerve that goes to the bladder, because it's all connected. So what you do is you come into the office once a week, and we put a little acupuncture size needle right next to that tibial nerve, which is right behind the ankle. And we hook it up to a little impulse generator, a little like remote control. It sends a little tap, tap, tapping down the wire to the needle, and then it goes up the nerve. And you'll just feel a little flutter or tap in the foot or going up the leg. It's very subtle. And you sit there for 30 minutes and you read your book or do your crossword puzzle, take a nap, whatever you want to do. And then after the 30 minutes are up, we take the needle out and you go on your way. Now, this is an additive treatment, which means that over time, the treatment gets better and better. Okay, so it's a 12-week course, once a week for 30 minutes. And it takes about 6 treatments for people to begin to really see results, meaning decreased frequency and decreased urgency. And this will affect the bladder particularly, but also can help with the bowel. And then by the end of 12 weeks, you're about as good as you're going to get and hopefully have excellent results. And then typically we plan to boost once a month just to keep that nerve up and working the way we want it to. So that is one option. The only issue with that is that it's a time commitment, right? You have to have time to come into the office once a week to do that, but it does work. The second option is Botox, which most of us heard of, but we haven't heard of it with the bladder, okay? So Botox is a muscle paralytic, and that's why we all use it in our face, right? The idea is that when you smile, the reason why the wrinkles show is because the muscles move, and as the muscles move, the skin on top wrinkles, okay? So if you inject a little bit of Botox in the face here, the wrinkles don't show. Okay, we're not going to do that, but we can take that same product and go in through the urethra with a little instrument, as you can see pictured here, and inject that Botox all around the bladder. So the bladder's like a balloon, and you just inject all over the bladder with a little bit of the medicine. It's a 5-minute procedure. You come into the office ahead of time. We put some numbing jelly in the urethra into the bladder and let it sit for 20 minutes. And then we go in with that instrument and inject all around the bladder. It may feel like being at the dentist with some pressure, but it shouldn't be painful. 5 minutes later, you're on your way out the door. And over the course of the next week, the bladder gets better and better with less frequency, less urgency, because it's inhibiting that bladder squeeze. That works very well as well. Low risk. The biggest issue with that is that it wears off. Okay, so that's great. If you have any problems, the one risk is that with this procedure is that we put a little bit too much in and you have difficulty urinating afterwards, either that you're not emptying all the way or that you even have to catheterize for a little while. But the beauty of it is that the medicine wears off, so that goes away. The bad news is if the medicine works really well, it wears off. And on average, people need to have this procedure about once every 6 months. This is also a great option. It has been around for the last 5 years, very successful. Tonight, I wanted to really take the opportunity to talk to you about what's pictured here, Axonics, which is the newest in our bag of tricks for how to fix the bladder. And the beauty of this is that it actually fixes the problem with the bladder and the bowel, okay? And it fixes both urgency and leakage as well as retention. So that's really a special treatment that can sort of work all different sides of the bladder issue. The concept is that the nerve that goes to the bladder from the spinal cord for some reason has been either turned up, so it's sending too many signals, go, go, go to the bladder, or that it's been turned too far down, so the bladder's not getting any signal to go, all right? Same thing with the bowel, that the bowel is getting too many signals, go, 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 to have a bowel movement, and you end up with leakage. So we have a new device now that is literally the size of a thumb drive that will fix the problem, all right? Now, this technology has been around for well over a decade, but it's been sort of new and improved recently. And I liken it to the iPhone 12, which isn't even out yet. It's the newest, latest, and greatest. Okay. What we do is we test first to see how you respond to this, because we want to make sure it's a nerve problem and not a muscle problem that's guiding your overactive bladder and bowel. So we have you come in and we put a little temporary wire next to the nerve that goes to the bladder. Okay. And we find, if you see this picture, the green is the sacrum, that's your tailbone, and there are automatically little holes in it. We all have them. And we find that little hole and we put a little tiny wire through it about the size of a piece of dental floss, and we set it right next to the nerve that goes to the bladder. Now, when we do that and we send that little impulse, just like with the tibial nerve stimulation, you will actually feel a little flutter or tap. For women in the vagina, labia, bicycle seat. For men, it could be in the scrotum or in the perineum, the area between the rectum and the scrotum. It's just a little flutter, but at the same time, your rectum will squeeze, which is why it works with bowel incontinence. And believe it or not, your big toe will curl. So we're looking for all those signals, and when we get it in the right place, we leave it there and we test it for a couple days to see how well you respond. And what we're looking for is a significant decrease in your frequency, urgency, and leakage, both bowel and bladder. And I just have to say that we've had a tremendous response with this, okay? Again, the product is called Axonics. And if you go online to their website, they've got, patient testimonials and all kinds of information about the product. But it is FDA approved for all of these conditions. The therapy works by what's called sacral neuromodulation. Sacral meaning that the nerve is in the sacrum, behind the tailbone, and neuromodulation because you're literally changing the signals that go to the bladder and the bowel, okay? So again, you're either turning up that signal if you can't go, or you're turning down that signal if you're going too much. So as this is pictured, and as I can show you here, incredibly tiny battery that sends the signal to the wire, which is again about the size of a piece of dental floss that's in position next to that nerve. This is placed in the buttock. You won't feel it. It's actually hard to feel. You have to reach around and palpate to feel it. So that's very nice. Nobody's going to see it. Nobody's going to know it's there, even in a bikini or your Speedo. All right. The other thing is that you can control this with this remote, okay? So this is like a little key fob. It looks like what your car key comes with. So you put it in your purse, nobody knows what it is, but you can turn your device off and on, up and down with this. So it's all very sexy looking, I have to say. But most importantly, it works. And not only does it work, but it is, as the picture shows, MRI compatible, which is new. Okay, so that's new technology. So you can have a head and full body MRI. Right now that's 1.5 T, but in the future it will be 3 Tesla MRIs. Pictured here is the remote. That's a better picture than what I show you here, but it's very easy to carry around with you and very easy to use. Now, this is a picture of the charger. The beauty of this battery, as small as it is that it lasts for at least 15 years. So basically, I can put this in and you can go away, the therapy's working, and come back well after 15 years for me to need to change this battery. But it is rechargeable as well. So you have to charge this about every 2 weeks for 1/2 to 1 hour at a time. And the way that works is by that little device, which you put on the charger right next to your phone charger. The remote here will show you when it's time to charge. And you take this and you put it right over the battery. And there is a little belt that it fits into so that you can be about doing the dishes, doing the laundry, watching television, whatever you want, while you're charging for 30 minutes. And it will tell you when the charging is done, or if there's any issue with the charging, it will have a signal and make a sound. The most amazing thing about this, I have to say, is this product, Axonics, just came out in November, and already they have over 90% efficacy at 1 year in patients. And I've been doing this product since November. And I have to admit that all of my patients have had excellent responses to the device, with at least 50% improvement, and many of them more than 80% improved. I mean, this is the wave of the future, and literally the best thing to come along in at least a decade. The data, again, you can look on the website. All the information is there. But this is going to take away all that pressure about changing where you're going and whether you can find a bathroom, and having to worry, having to buy boxes of pads and have them delivered by Amazon so nobody knows what they are. And I know that happens. 90% of people have lasting improvement at 1 year. So this is a home run by any stretch. The one thing I want to say in closing, I really recommend people talk to their doctor about this and do some research. With this, you can forget pills, which dry you out and bind you up. You can forget the exercises, which of course we all know we've all forgotten anyway, because we never remember to do them. And I can set this and forget it. Put it in. If it works for you, we can put it in and you forget about it and go on your way. That's huge, particularly with bowel issues, but also for bladder issues. So it's a whole new world out there for people who are suffering from overactive bladder. If you have any questions, please email through so we can answer them. But most importantly, talk to your doctor, talk to your gynecologist, talk to your primary care doctor, go online and look up Axonics. Go on Chesapeake Urology's website. You can make a telehealth appointment and meet doctors virtually. You can come into the office, but we'd be happy to take care of your problems anytime. Thanks so much for your time.
Thank you, Dr. Hawes. We have several questions that have been submitted. All right, Dr. Hawes, the first question comes from Kara. She would like to know what level of bladder or bowel involvement qualifies a patient for Axonics.
That's a very good question. With bowel, pretty much all levels are possibly tested and treated. It can't be a physiologic problem such as when people have Crohn's disease or ulcerative colitis. If they have an underlying disease that's causing the incontinence of the bowel, that underlying disease needs to be treated. So this is really for people that have a nerve cause for their fecal incontinence. But anybody who has that, they've been evaluated by their gastroenterologist and they can't find anything wrong, and they tell you to do exercises and things like, all those people should consider being evaluated. Literally the test is a 3 or 4 day test. So you have nothing to lose by trying it. It's easy to do. The only thing we ask is, because those wires are small, that you don't do a lot of heavy exercise during the time the wires are in. But you have nothing to lose by trying it. And it's such a social issue, it's worth a try. As far as bladder, again, it has to be, it can be a neurologic cause, such as MS. Patients with MS are now considered for this therapy. For MS in particular, multiple sclerosis, this was never a therapy option because you needed MRIs. Now that whole window is open. But if you have leaking of urine because of laugh, cough, lift, sneeze, which is stress incontinence, it's not designed for that. If you have what's called intrinsic sphincter deficiency, where the bladder neck is just not tight enough, it's not going to help with that. So we just have to make sure it's the right kind of incontinence. But it doesn't matter whether it's just a little leak or whether it's a large leak. This is a quality of life issue. So when it's bothersome enough for you to seek treatment, that's the answer.
will the axonics device be detected by a metal detector?
So the reason why this is MRI compatible is it has a ceramic end that you can communicate through, but the metal is not changed or does not respond to the MRI, which is a huge magnet. However, when you go through a metal detector, it may, like at the airport, it may well be detected. So when you go through the airport, we give you a little card, just like as if you had a pacemaker for your heart or you had a hip replacement. You have a little card that you show them at security, and they will probably pat you down. So it is possible that it can be detected. There are all kinds of metal detectors, so we usually tell you just to tell someone up front.
Thank you. Next question is from Sue, who says she has been unable to find information on the effectiveness of the axonics device for individuals over the age of 75.
I must say that many of the patients who suffer from this are over the age of 75. And at least in my experience, since November when this has been put out, it's been excellent. The biggest issue is your ability to use the remote, really, and keep a diary. But it is not in any way a problem. Age is not an issue. And I know it's a little more intimidating because, once you start talking about chargers and remotes and all that, a lot of people get a little gun shy. It could not be simpler. If you can turn on the TV, you can easily manage this. But it's very efficacious in older patients. I would say more of my patients are Medicare age, which is 65 and older, than under.
We've had several questions about whether or not Medicare covers this treatment. Is that something you can talk about at all?
Absolutely. Medicare does cover this treatment. The issue is that Medicare covers 80% of all your treatments, and then you have this 20% copay, which hopefully a secondary insurance will pick up. Well, a secondary insurance, if you have one, will pick it up, but you have to have one. Medicare absolutely pays for this. Typically, for most insurances, they want a patient to have tried exercises and diet changes, which most of us have tried anyway before they even bother going to the doctor. And they like you to have tried one or two medicines or not be able to try them either from allergies or constipation, some side effect, before they'll want you to go ahead and try any of the third-line therapies. And they like a more conservative approach, but they will absolutely pay if we've gone through the appropriate algorithm.
This question comes from Kay. She says, I have leakage all the time, but never sense that she needs to urinate. I'll be standing at the sink and all of a sudden I feel myself urinating. She's wondering if that is overactive bladder.
It may well be. There are some other things that can be going on. So for that, what we would do before we go ahead and just test the axonics, we would just do some neurologic testing for sensation, for motor strength, things like that. So that would require an evaluation just to make sure. We don't want to do a procedure that, if we're missing the target, what might be going on. But absolutely, I have patients that have had no sensation to go, or no sensation to go till they're really, really full, and it has helped.
Next question is, if I've had Botox in the past and it worked well, does that get rid of the chance of needing catheterization in future treatment?
If you've had Botox in the past and it works well, if you keep getting the same dose, your chance of needing catheterizations in the future is very low. It's not like over time, the more Botox you have, the less likely your bladder is to be able to contract. It doesn't work that way. So you don't need to worry. Now, there are several doses of Botox, so you have to make sure you stay at the same dose. If you were to increase your dose from 100 units to 200 or whatever, then absolutely you could have retention again.
There are a lot of questions about the PTNS treatment. People are asking, if there are any side effects, how often you have to continue it, and what the name is. Again, if you could go over that, please.
Sure. P as in Peter, T as in Tom, N as in Nancy, S as in Sam. Peripheral tibial nerve stimulation. So basically, the tibial nerve is the nerve that runs down the inside of the leg down to the ankle, okay? And so peripheral means that this is done on a peripheral extremity, okay? So not centrally, but somewhere out further away from the body. So it's in the ankle, so that would be the peripheral. Tibial nerve is the nerve that runs down to the ankle. nerve stimulation, okay, PTNS. So that treatment is actually very safe. There are minimal risks. The biggest risk is a little irritation at the skin or possibly an infection where you put the needle in at the skin. I've never actually seen that, either one of those, but that is possible anytime you put something into the body. But the biggest risk I would say is that it doesn't work as well as you'd like. But really there are no risks, like no risk of blood clots or bleeding, damage to the nerve, nothing like that. The only issue is the maintenance of it, like someone alluded to and asked about. So you do this 12-week treatment. Let's say you're 70% better. You can't just walk away. We usually do a boost once a month. You come in and we give you a booster treatment. And that in theory is, long-term, you need to do that.
The next question is from Jean. She asked, does axonics work when you have a retrocell as well as OAB?
Overactive bladder has to do with that bladder being overactive and out of control. A rectocele is basically in the vagina. The tissue of the vagina can thin over time, and then the bowel pooches out, okay? That can happen in the bowel, that can happen with the bladder, or the uterus can come down. All right, so when that rectocele typically happens because of chronic constipation or trouble having bowel movements. And the worst part is then when you get that pooch, that rectocele where the bowel is pushing into the vagina, then the stool tends to get stuck there, and then it's harder to have a bowel movement. So it's like a snowball effect. But the rectocele does not affect the bladder function in that way. So axonics will absolutely work for that. It may not help with the bowel movements, and a lot of times if the rectocele is bad enough, you may need surgery to fix that. Ideally, you don't, because the surgery is a little uncomfortable afterwards. So anything you can do for your rectocele to keep things moving, whether that's stool softeners, Miralax, magnesium, there are a bunch of different ways to keep the bowel moving. That'll help with your rectocele. But the axonics is absolutely still possible with that.
Okay, the next question comes from Nancy. She says, in axonics therapy, is the wire placement the same for both urinary and bowel, or are these two different mechanisms?
The wire placement is exactly the same. So let me just talk about that a minute. You come into the office one day, we lay you on a table on your stomach, and we use a little x-ray to find that hole that you saw in the picture. And then we numb up the skin and we take a little needle and we go right through that foramen, okay? And the nerve sits right behind there. Okay, so when we get that needle through that little foramen, then we send a little stimulation down that needle, again, looking for that, you to tell me you feel it, and for the toe to curl and for the rectum to squeeze. And when I get that stimulation properly, then we take the center out of the needle and put the wire through it. Okay, so there's no more sticking or poking or anything like that. Then we leave the wire in and remove the needle and tape it down. Okay, that nerve root that we've just set the wire next to actually doesn't split till further down in the pelvis to go to bowel and bladder. So with one needle placement and with one wire, you can affect both.
Okay, and our last question is, this person is drinking a lot of cranberry juice for UTIs, and she's asking, can that cause OAB?
That is a great question, and absolutely. So cranberry juice is very acidic, so it can be very irritating to the lining of the bladder if you're sensitive to that. And that's why usually I recommend the cranberry pills, just because there's no acid in those. The other problem is that cranberry juice often is cut with something like, apple juice, grape juice, whatever. So you need a lot of cranberry juice to get enough proanthocyanins, which is the effective part to help prevent infections. So you need a lot of juice. And of course, that can be a lot of calories also. So usually I recommend the pills instead of the juice.
Darlene just submitted a question and asked, can frequent constipation cause urinary leakage?
I usually tell people absolutely. Constipation can definitely affect the bladder both ways, okay? If there's a lot of stool in the rectum, it can make it hard to empty the bladder. But also, a lot of stool in the rectum puts a lot of pressure on the bladder, and the bladder senses that pressure and says, oh, there's pressure here. It must be time to go. It's not that you need to urinate, but the bladder doesn't know that. It just senses pressure. So it tells you go, go, go. So constipation will definitely give you frequency and trouble emptying. And oh, by the way, it increases your risks of bladder infections. So anything you can do to keep your bowels as regular as normal, I tell all my patients that. So some of the things you can try, magnesium works great. If you get too much magnesium, and actually will give you diarrhea, so you just want to get like a magnesium citrate pill and titrate up to effect. Stool softeners work, FiberCon, Metamucil, or eating fiber. Miralax works well. I just recommend that people stay away from stimulants, laxatives, because then the bowel tends to become dependent on laxatives. So you do not want to maintain your bowel function with a laxative. Every once in a while, fine, but not regularly. But absolutely, your bowel function will affect your bladder in a negative way.
Okay, one last question. Is PTNS covered by Medicare and insurance?
Absolutely, yes.
Okay, that's the last question we had. I just want to thank Dr. Hawes for her time and thank everyone for joining us. If you have any questions, your question did not get answered, or you would like more information, please contact us at chesapeakeurology.com/telehealth, and we look forward to hearing from you. Thank you, everyone, and have a good evening.
Thank you very much for your time. I appreciate it.